our speech today about building confidence now and for the future for Galvus. Verifying the diabetic patient futures. Abraham Lincoln, the 16th president of the United States, tell us that I would never allow a scientist to partake in my government, give them a new piece of information, and they are liable to change their mind. And this is, of course, against policies. My agenda: the rationale behind remaining diabetes, the verified trial overview, the new evidence for early treatment intensification verified trial, the AASD and AASD 2020 updated consensus report. Do young onset diabetes or late onset diabetes benefit more from the early combination therapy? Effect on beta cell function in new diagnosed type 2 diabetes leads after treatment. It's time to act. Patients with type 2 diabetes cannot buy back time, but you can help. It's time to act. Despite suboptimal glycemic control, physicians typically delay treatment intensification. For the uncontrolled patients, guidelines recommended earlier treatment intensification to help. This can achieve and maintain earlier glycemic control, improve long-term outcomes, and reduce the risk of future complications. As we know that, despite this optimal glycemic control, treatment intensification is typically delayed. The new approach treatment for early type 2 diabetes mellitus, the new approach is the early oral antidiabetic therapy combination. As we know that, pharmacological approach to treatment of diabetes mellitus, drugs in combination to act on the multiple pathophysiological defects, treatment targeting the pathogenic abnormalities and not simply reducing hemoglobin A1C, early treatment intensification to prevent or slow the decline of beta cell function. Early combination therapy as a strategic approach, synergistically tackle multiple pathophysiologic mechanisms, potentially resulting in more durable treatment effect without increasing the risk of adverse events. Since type 2 diabetes is progressive disease with early onset of complications, current treatment paradigm with metformin unable to achieve the required glycemic control, need for new evidence for early treatment intensification, which is the verified. What is the solution? Together, vildagliptin and metformin acts on key underlying defects of type 2 diabetes. This is really a very good combination. Why? Because the glucose-dependent mechanism of action of Galvus targets both alpha and beta cells, and therefore both insulin and glucagon, to stimulate beta cells to increase insulin secretion and stimulate alpha cells to decrease glucagon secretion. While metformin acts on insulin resistance, so that this combination is really a perfect combination. This combination has a powerful reduction with vildagliptin in combination with metformin. It reduces hemoglobin A1C by about 1.1%. This combination has an established safety profile. An established safety profile regarding hypoglycemia. Fewer hypoglycemic events with Galvus versus sulfonylurea as add-on to metformin. Regarding weight neutrality, it doesn't increase body weight. Regarding the cardiovascular safety, there is good tolerability and overall cardiovascular safety. So that this drug has been proven to be effective drug and multiple mechanisms of action and a safe drug with fewer side effects. So that this is the time of Galvus. It delivers powerful hemoglobin A1 reduction by 1.1%, has an established safety profile with no increased risk of hypoglycemia, weight neutrality, good tolerability, and well-documented cardiovascular safety, has a glucose-dependent mechanism of action that complements metformin to tackle the key underlying defects. So that powerful, safe, with minimal or few side effects, and has a complementary action with metformin. So that here comes the idea of the verified. The verified This studied glycemic durability of an early combination therapy with vildagliptin and metformin versus sequential metformin monotherapy in newly diagnosed type 2 diabetes. Verify. This is a 5-year multi-center randomized double-blind trial. Verify the role of initial combination therapy in patients with type 2 diabetes. Here the study. The first arm is the previous, we all thinking about sequential strategy. Shall we add the 4 inhibitor to current treatment? This was 2016. But by verified trial, we have a new concept, which means that early combination of the two drugs challenging the current practice. What if you could offer your type 2 diabetes patients a new approach to their treatment early from the beginning 3 years ago? When we have compared the concept starting from the QPDS 1998 up to verified 2019, there is a great change in the concept. Previously, most of the studies, such as the VADIC, LEADER, DECLARE, ACCORD, CANNABIS, CARMELIA, EMBAREG outcome, and SAVORTIMI, and ADVANCE, ADOPTICOS, UDPKS, and its follow-up, they didn't intensify reduction of hemoglobin C when you're below 7%. But verify have changed the concept. What about intensification of therapy at hemoglobin A1C 7%? Let us see. This study is a multinational and multi-ethnic study, have included 34 countries with 254 centers, including about 2001 population. It has several stages. Within 3 weeks, we are upgrading the dose of metformin, 500, 1000, 1.5 grams per day. And then we have 2 arms. An arm is monotherapy arm, metformin plus placebo. The second arm is metformin plus vildagliptin, which is an early combination. A visit will be done every 3 months and will make hemoglobin A1C every 3 months and the failure if your hemoglobin A1C is exceeded 7. For the combination arm, if they have failed, still in combination, even failed or not failed. But at period 3, if total failure, you will change to insulin. While the monotherapy, if you have a failure, here you will move to combination therapy, and at the end, if you have a failure, you will change to insulin therapy at period 3. This is here the concept. The verified study design, including several varieties. The age, including from 18 to 70 years old, body mass index 20 to 40 kilograms per square meter, hemoglobin A1C ranging from 6.5 to 7.5%. GFR is normal, above 16 milliliters per minute. Type 2 diabetes diagnosed less than 1 year. Drug naive, maximum 4 weeks of metformin. So that, let us see what this study will present. It have included several varieties. Low hemoglobin A1C levels, obese patients, smoker, non-smoker, ethnically diverse, preserved beta cell function, men and women, younger population, so that it is of diverse population. We included real life patients, 20%, 52% from Europe, 27% from Latin America, and Africa, Australia, and Asia. Regarding the gender, comparable gender with slight majority towards women. They have included both obese and non-obese patients. The body mass index below 30 have represented in 53% of our patients. Smokers and non-smokers, about 15% of the patients were smoker. The median age, 55 years old, with the spectrum from 18 years up to 70 years old, so that they have included from young up to old ages. Lower hemoglobin A1C, they have started with mean hemoglobin A1C 6.7, so that this is here the change in the concept. Your patient hero, how can verify change your patient life? Main results and safety. For the analysis of this study undertaken, we have a primary analysis, secondary analysis, and exploratory analysis. Primary analysis, time to confirm initial treatment failure. As we can see here, primary treatment failure, this means that when we have monotherapy has been failed after how long a duration? So that the question is, do those with type 2 diabetes benefit from having combined therapy at the beginning of their pharmacological treatment? Is a very important question. The answer that early combination treatment strategy significantly reduced relative risk of time to initial treatment failure by 49% versus initial monotherapy strategy. So that you have saved 50% of your diabetic patients. And I remember you that the endpoint or the failure, if your hemoglobin A1C exceeded 7%. Your patients here, you have by 2 years, have 2 extra years of glycemic control with the early combination therapy. So that you have bought another 2 years for your patient. This is a great achievement. What about the secondary analysis? Progression of hemoglobin A1C after the start of period 2 to the end of period 2, assessed by rate of loss in glycemic control over time, by threshold secondary failure and the slope of glycemia. Let us see, when you have secondary failure, which means that at the end of the period that the combination has been failed, you will add here basal insulin. So the question is, do those with type 2 diabetes benefit more from having combined therapy at the beginning of their pharmacological treatment compared to a sequential active strategy? Let us see the answer. The answer was very important because the relative risk for time to second treatment failure during period 2 was significantly reduced by the early treatment combination by 26% versus monotherapy. So that this is another achievement. What about safety and tolerability? As we can see here, this combination was really safe, even if you have started and with intensification of hemoglobin A1C 7 with comparable hypoglycemic events. Even these comparable hypoglycemic events, the hypoglycemia mostly mild with no serious side effects. Regarding reduction in body weight over 5 years from baseline, it doesn't increase body weight. The average was loss of the body weight by 1 kilogram, which is of non-statistical significance. So that there is no significance between the two groups in your increase in body weight, so that this was a very safe combination therapy. As we can see here, regarding serious side effects or not serious side effects, here were very comparable with no significance between both groups, and the discontinuation of the adverse events was comparable between the two groups. And as we can see here, regarding side effects, regarding adverse side effects, severe side effects, all serious side effects, it was comparable between two groups, so that this combination therapy hasn't increased our adverse effects in these patients. What about the exploratory analysis? Let us see what we have found regarding cardiovascular event. The total confirmed adjudicated cardiovascular events, although verifier was not a cardiovascular outcome trial, all the cardiovascular events were subject to adjudication. The adjudication was performed by an independent committee masked to the treatment strategies, and independent committee monitored the cardiovascular safety. In spite of this, there was no statistically significant issue, but numerically, the number of cardiovascular complications have been reduced when compared with initial monotherapy. But I will stress, statistically, there weren't significant. As you can see, here the number of complications in the early combination therapy was much lower than those with monotherapy, but still of no significant statistical significance. So that summary and the clinical implications. On that, in combination group, 3 out of 4 patients have achieved hemoglobin A1C below 6.5 at 3 months. 75% of your patients, when compared to only 50% of the monotherapy patients. We found that these 3 out of patients have achieved below 6.5% at 3 months and kept it for at least 1 year. Not only have achieved in the first 3 months, but you have kept that in the first 1 year. It is important, yes, it is very important, because strict glycemic control in the first year improves the future type 2 diabetes mix outcomes. Risk reduction from hemoglobin A1C levels below 6.5 versus 7 to 8 in first year in a study with 13-year follow-up. Let us see the difference. If you have made a strict control in the first year below 6.5%, you will have reduction in microvascular complications by 39%, reduction of the macrovascular complications by 29%, and reduction of mortality by 29%. So that it's a very important achievement. Tight glycemic control maintained over 5 years, not only for 3 months or 1 year, by about 40% when compared to 28% in the monotherapy group. So that this early combination therapy enables more patients to continuously achieve pre-diagnostic hemoglobin A1C over 5 years. So that this is very important issue. When we'll find your early type 2 diabetes mixed patients can enjoy better glycemic control with an early combination therapy. So that here, about 56% of your patients, when compared with monotherapy, about 38% of patients, so that you have achieved a very important issue. What about the risk? Relatively risk of achieving hemoglobin A1C below 7 at 5-year patient group, there is no significant risk. There is no significant adverse side effects, as you can see in this diagram. As you know that the problem is that progressive type 2 diabetes leads increased complications and limit therapeutic choices. So that it's very important to prevent, again, mortality, cardiovascular outcomes, cardiac complications, for strict complications in the first year, and for tight control in the first 5 years, and for a better, of course, control by combination therapy. Is this important? Yes. As per UKPDS, as 1% drop in hemoglobin A1C have made a great difference. It results in 12% reduction in risk of stroke, fatal and non-fatal, 14% reduction in myocardial infarction, 37% reduction in the microvascular endpoints, 43% reduction in the risk of amputation or death from peripheral vascular disease, with decrease over mortality rate by 21%. So that it's a great achievement. So that for our key findings, the early combination treatment halved the risk of time to initial treatment failure versus monotherapy. Median time to failure was 3 years in the initial monotherapy strategy, compared to over 5 years in the early combination strategy. You have by the extra 2 years. When all patients were receiving combination therapy, the risk for time to second treatment failure reduced by 26%, and this is another achievement. Both approaches were safe and well tolerated, so that you have achieved more control, more strict control, lesser incidence of failure without any side effects, and with a great range of safety. So that in this condition, start with vildagliptin galvasmid for newly diagnosed and uncontrolled patients, because durable hemoglobin A1C control over 5 years with positive impact appearing early from the first 6 months, consistently lower hemoglobin A1C levels, particularly in the first year, which is critical for future outcomes versus monotherapy, comparable durability with no increased risk of hypoglycemia or weight gain versus metformin. So that the strategy of an early combination treatment approach with this drug in patients with newly diagnosed have significantly and consistently improves long-term glycemic durability compared with metformin monotherapy. These have broken the previous consensus, because previous consensus in the AD and AASD, there is no any proof that sequential therapy, or early combination therapy will be superior on sequential therapy. But we have certain quotations to change our mind, Lancet quotations. Previous studies have established that use of early glucose lowering treatment with metformin for the management of type 2 diabetes is associated with a reduction in morbidity and mortality, and a legacy of continued benefit after 10 years. Recent short-term studies of metformin combination with different anti-hyperglycemic medications have suggested improvements in glycemic outcomes, but also highlighted the importance of achieving early glycemic control within the first 12 months and first year. An area of evidence confirms the progressive nature of early type 2 diabetes, but also a clinical reality of inertia in therapy intensification, and thus a combination therapy approach with 2 classes of synergistic drugs early in the disease continuum is intuitively assumed to be more beneficial than later intensification therapy, and this is the concept. However, before verified results, long-term glycemic durability and the clinical benefits beyond the glycemia of early combination strategies have not been investigated yet, and so cannot be recommended. But this study have changed the concept. So that here is starting from 2019, update, management of hyperglycemia in type 2 diabetes, consensus report by the American Diabetic Association and the European Association, the study of diabetes. These have changed the concept. They have recommended that here that there's a superiority for early combination therapy when compared with monotherapy, and here is preferability is for vildagliptin, because this was the start of this issue. So that, well, as previously started, there was limited evidence for initial combination therapy. Vildagliptin efficacy in combination with metformin for early treatment of type 2 diabetes verified trial provides additional information. The initial combination of the DB4 inhibitor, vildagliptin, and metformin was shown to provide a lower rate of secondary failure of glycemic control if hemoglobin A1C versus metformin alone, or the sequential addition of metformin and vildagliptin. These results have been generalized to other orals than vildagliptin. We now suggest that providers should engage in shared decision making around initial combination therapy in new onset cases of type 2 diabetes mellitus. So that the guidelines have changed their mind. The ADA, AASD, ACE guidelines all recommend earlier treatment intensification with a second oral agent if patients have not reached their target after only 3 months. Intensification treatment sooner allows patients to achieve and maintain individual hemoglobin A1C targets. Therapies with complementary mechanisms action should be used in combination for optimum glycemic control. This is now is the new concept. So that the UKPDS have recommended intensification of therapy will preserve beta cell of pancreas induced diabetes complications and benefits of early complication therapy with galvasmid and how it affects the durability of glycemic control. So that this is the new concept. Let us discuss the other issue, young onset diabetes. Do young onset diabetes or late onset diabetes benefit more from the early combination therapy? Let us discuss that. Early combination therapy delayed treatment escalation in newly diagnosed young onset type 2 diabetes. A sub-analysis of the verified study. The background here, as we know, young onset diabetes is an emerging epidemic as 16% of the total global adult population with type 2 diabetes mellitus are diagnosed before the age of 40. The lack of long-term efficacy and safety data of pharmacological interventions may contribute towards the delayed treatment initiation and intensification in those patients with young onset diabetes mellitus. So that the recruitment of newly diagnosed treatment-naive patients with type 2 diabetes from 18 to 70 years old in the verified trial enabled us to evaluate the early combination therapy compared with metformin monotherapy among patients with type 2 diabetes diagnosed before young onset diabetes and after late onset diabetes, the age of 40 years old. Let us see the objectives. To evaluate the efficacy and safety of vildagliptin plus metformin combination approach in patients with young onset diabetes versus those with late onset diabetes. The primary endpoint, time to initial treatment failure, defined as hemoglobin A1C as 7 or higher at 2 consecutive scheduled visits after randomization in both young onset diabetes and late onset diabetes patients, either on early combination or on monotherapy. Secondary endpoint, the time to secondary failure was assessed in both young onset and late onset patients, either on early combination or on monotherapy. Let us see the results. The primary endpoint, you have this early combination therapy have reduced the incidence of the failure by 48% in young onset diabetes when compared to late onset diabetes by 46%. So that you have halved the incidence of failure. Very important. For the secondary endpoint, the results were more and more very promoted, because the incidence here for secondary endpoint was about 48% when compared with late onset diabetes 24%. So that this was very effective and great results. So that conclusion, in patients newly diagnosed with young onset diabetes and with hemoglobin A1C of 6.5 to 7.5, the verified study showed that early combination strategy of vildagliptin plus metformin improved the attainment of glycemic targets with durability and late treatment escalation compared by with sequential treatment of metformin followed by addition of vildagliptin. What about the very important issue, the effect on the beta cell function in newly diagnosed type 2 patients after treatment with vildagliptin and metformin? Results from also the VERIFY study. Let us have the issue about this consensus. What are the consequences of clinical inertia? The burden of microvascular complications type 2 diabetes. Diabetic nephropathy, leading cause of end-stage renal disease in Worcester County, 44%. Diabetic retinopathy, leading cause of visual loss in adults. Diabetic neuropathy, leading cause of non-traumatic lower limb amputation, 60% in the States. So that this is the burden of the microvascular complications. What about glycemic intervention strategies? All the studies, different studies, have reduced microvascular complications. Some of these studies, in addition to reduction of the microvascular complications, have proved to reduce cardiovascular complications and mortality. And overcoming clinical inertia will preserve beta cell function. As you know that beta cell responds to an increment glucose with an increment insulin in proportion to the body's sensitivity to insulin. So that when you are making a proper control of blood glucose level, this will preserve the beta cell function of the pancreas. But diabetic patients, because of the poor control of diabetes mellitus, this high glucose level will make these patients losing 80% of beta cell function. So that this is very bad news. Let us see the usual previous behavior. Usually, previously, the physicians, how can be adding to inertia according to sequential intensification step. Firstly, they add one oral antidiabetic therapy, and after about 1.6 to 2.9 years, they will add a second agent, and after about 7 years, they will add a third oral antidiabetic agent, and after 6 to 7 years, they will add insulin. And after about 3.7 years, they will add GLP-1 receptor agonist and premixed and bolus insulin, so that we have a great lag of time, and this is the clinical inertia, and we are paying hardly the price of that. So that delays in intensification of therapy, usually clinical inertia occurs at each stage of sequential treatment intensification. So that we should try to escape that by the new concept of verified trials. Let us see what about the analysis undertaken, exploratory analysis. What about HOMA2, homeostatic model assessment for beta cell function and insulin resistance? The background: despite the increasing use of incretin-based therapies, there is a substantial uncertainty and limited literature evaluating their effect on beta cell function and preservation. The objective: to determine the effect of early combination treatment approach using vildagliptin plus metformin versus sequential intensification of metformin monotherapy approach on beta cell function in newly diagnosed patients with type 2 diabetes mellitus enrolled in the VERIFY study. Study assessment: as per the pre-specified analysis plan, the change in beta cell function was assessed by homeostasis model assessment for the beta cell HOMA-B from baseline to end of period 1. The results: among these, the annually change in beta cell function was evaluated in this type of patients in the early combination and the initial monotherapy groups, respectively. Median time to loss of glycemic control is time to end of period 1. Among these individuals was 61% versus 36.1 months. The mean HOMA at baseline was 120 when compared with 114 in the early combination and the initial monotherapy group, so that it was the same nearly baseline. Just the adjusted mean change in HOMA-B from baseline to end of period 1 was 17.2% in the early combination group versus minus 2.02% in the initial monotherapy group. Let us see this data. So the results: the difference between early combination and the initial monotherapy treatment approaches at the time of initial treatment failure was 19.2, because we have 17 and minus 2, so that it is of highly statistical significance. And this is the result. When you have early combination therapy, here the HOMA-B from baseline is markedly improved, while those without initial combination therapy and proper control blood glucose level, they have a lower, of course, HOMA-B, so that it's of a great value and great achievement to preserve our beta cell function of the pancreas. So conclusion: the early combination treatment with vildagliptin and metformin in patients with newly diagnosed type 2 diabetes mellitus showed improvement in beta cell function compared with metformin monotherapy. We should understand what our patients need in life. What do patients with diabetes want from their treatment? They have several problems and we should help them to solve these problems. We have a problem that hyper or hypoglycemia, fluctuating blood glucose levels. This will produce the hyper and the hyper fluctuation, frustration, fatigue, required courage to handle. The expectation from us to lower risks of hyper or hypoglycemia and the fluctuating blood glucose level. This is a very important problem. Another problem, late micro and macrovascular complications. And this will produce an anxiety for our patients, so that we should try, and the expectation, to reduce long-term complications. A third problem, lifestyle restriction and reduce the quality of life. Don't eat, restrict, so that at the end, where emotionally there is loss of control, treatment and devices match to individual needs. It's very important because the patient at the end is telling us, I want to live a long and happy life. So that start with vildagliptin metformin, galvasmid, for newly diagnosed and uncontrolled patients because it offers early combination treatment, half the risk of time to initial treatment failure versus monotherapy strategy. Median time to failure was 3 years in the initial monotherapy strategy compared to over 5 years in the early combination strategy. When all patients were receiving combination therapy, the risk for time to second treatment failure reduced by 26%. Both approaches were safe and well tolerated. Also, another value in patients with newly diagnosed with young onset diabetes mellitus, early combination therapy of vildagliptin plus metformin delayed the initial and secondary treatment failure by about 48% versus the sequential approach. The early combination treatment with vildagliptin and metformin in patients with newly diagnosed type 2 diabetes showed significant improvement in beta cell function when compared with metformin monotherapy alone. For that, this combination offers a new treatment approach for early type 2 diabetes mellitus management so that our future is saved and verified. And thank you. Thank you, sir.
هيبقى في discussion ولا لا? Will there be a discussion here?
If there's questions, yes, please. Thank you very much, Professor Hussein. Very informative. And I think we're having some questions for you about Galvas vildagliptin.
Okay, I'm waiting, Doctor. Thank you.
What about Galvas with diabetic with hyperuricemia and CKG?
Yes, this is a very important question. When you have hyperuricemia, in this situation, Galvas doesn't add hyperuricemia and it is not contraindicated, and there is no problem in hyperuricemic patient to use Galvas therapy. For CKD patients, when you have GFR above 50 milliliter per minute, you can use the full dose of vildagliptin, but when you have GFR below 50 milliliter per minute, you should halve the dose. This is a very important question. Regarding metformin, you can use the full dose of metformin if you have GFR above 45 milliliter per minute. And when your GFR is reduced between 30 to 45, you can halve the dose and reach up to 500 milligram per day, or below 30 milliliter per minute. It is absolute contraindication to use metformin, in spite that some trials are using in dialysis patients and below 30 milliliter, but this is against the recommendations and the guidelines. This is the answer for the first question.
And for CKG, use of vildagliptin for CKG patients, diabetic patients?
Vildagliptin, we can use when the GFR above 50 milliliters per minute, we can use it in the full dose, which means 50 milligram twice per day. But when we have GFR below 50 milliliters per minute, we are halving the dose to be 50 milligram once per day. And it can be used even on dialysis patients, but by halving the dose and reduction of the dose of the vildagliptin. This is the answer regarding the CKD patients and dialysis patients.
Another question about if galvasmet is superior to metformin in cases of metabolic syndrome and insulin resistance. This is the first part of the question.
Yes, of course. When you are trying to give galvasmet from the start, you have several points. Of course, you have a lower target of hemoglobin A1c, and this will help the metabolic syndrome. In this situation, you will preserve the beta cell of the pancreas so that you are preserving your pancreas, and this will be very helpful. And of course, with better control of blood glucose level, you may have a better control of the lipid profile. In this situation, you may have, of course, in addition, a control of lipid profile. And if the patient is receiving metformin and this may help in the body weight, this may be helpful. Despite that, vildagliptin has neutrality towards body weight. It doesn't increase or doesn't reduce, so that it doesn't adding harm to the metabolic syndrome, but it will add a benefit for the metabolic syndrome, especially regarding the beta cell function of the pancreas and delaying and improving of insulin resistance.
Use of galvas with type 1.
Use of galvas with type 1. I don't think that with type 1 we are in need to use the galvas. Galvas, when it is prescribed for only type 2 diabetes mellitus, while type 1, I think it is to be treated with insulin only. And I don't recommend to add galvas for type 1 diabetes mellitus, because according to the mechanism of action, it will act on the pancreas. Its benefit will be very limited.
What's the maximum dose of vildagliptin?
The maximum dose vildagliptin, if we are 50 milligram twice per day, it's the recommended dose. We are usually giving maximum dose 50 milligram twice per day, while in CKD patient with GFR below 50 milliliters per minute, we are using 50 milligram once per day.
And comparison of vildagliptin metformin to GLP-1 receptor agonist in patients with insulin resistance.
Of course. Usually when I am comparing, this comparison is not a fair comparison, because all the guidelines have put metformin usually as a step 1 regarding the guidelines, associated with modification of lifestyle, and then there is an adding drug, so that I can't compare any drug to metformin because of its superiority. All the guidelines all over our history adding number 1 metformin to be the first drug of choice, then to add on other medications according to the situation. The GLP-1 receptor agonist is a very important drug in cases of when we have CKD patients and in cases of heart failure or cardiovascular disease patients. But apart from that, there is no superiority for this drug over vildagliptin metformin. And I think this is unfair comparison, because you should, in any therapy, you should starting with metformin and add on, so that the superiority will be for vildagliptin metformin.
Okay, these were the questions, Professor Hussein. And Professor Omar, do you have any comment or question?
I have a small comment to my dear colleague. I enjoyed very much late onset diabetes and young onset diabetes. حلوة جديدة. يعني it deserves. I'd like to ask you a little question. It came to my mind while I was preparing for adolescent diabetes type 2 in the young. they said not to use any drug غير اللي recommended بالاي دي. قالوا كده وحطوا ميتفورمين ذا فيرست لاين خلاص، وراها بيزل انسولين، وبعدين نطوا على ليراجلوتايد. It came to my mind, why use injections, why not try فيلدا او سيتاجليبتين؟ ايه رايك؟ الجايد لاينز 2022 عامله كده، ما حطتش الدواء ده بس حطت اللي اجمد الليراجلوتايد. رايك كيف الكلام ده؟
انا حضرتك رايي الشخصي حضرتك طبعا احنا when we have guidelines I think we should respect of course the guidelines, but according to this study they are recommending that we can use vildagliptin plus metformin as a combination therapy. I don't think that in adolescent we have any contraindication to give this safe drug. Inhibitors are acting in a very
all the doctors are giving it, بس الجايدلاينز قالت الدواء الليراجلوتايد، وانا مستغرب يعني بس it's a nice point يعني عارف why not try it يعني.
Yes, I think trial.
هل يا دكتور عمر في الاستادي دي كانوا اوبيز يعني؟
ايه؟
كانوا اوبيز في الاستادي
دي؟ كل تايب 2 في الادلت في اليانج برضه بيبقوا اوبيز وانسولين ريزيستنت.
ما يمكن علشان كده.
يعني انا يعني ليه كتب ليراجلوتايد وحطه بالاسم؟
بس هو كان الدكتور عمرو كان المفروض يحدد لي، كان يقول لي
مش عارفين الاستادي كانت ايه الاستادي نفسها.
لا انا بتكلم على الجايد لاينز 2022 اللي هي اللي انا اخدت منها التوك.
سواء لو كان
هو عشان التايب 2 ادوليسنت دولت هيبقوا عاده اوبيز.
انا بس يعني استعجابي كان ايه؟ طب ما كنت حطيت الفيلداجليبتين خلاص يعني اسهل والعيل يعرف يبلعه وانتهت القصه، ولا انا كلامي غلط؟
هو يمكن عايز يخسسه بقى يعني في حاجه ثانيه يعني غالبا. بس لو قرينا الجايد لاين ده مكتوب اللي هو بقى الشرح بتاع مش جاست الريكومنديشنز، الشرح نفسه بتاعها ممكن نلاقي الاستادي دي كانت معموله في الاوبيز.
بس اتس فيري انترستنج ستادي على فكره يا دكتور ياسين.
يس بس
هم حضرتك بيعملوا
ساعات كومنت يعني عارف مش
ديفرنت ايجز، فعشان يقول لك ان هو فور سيفتي، انه يقول لك ان ده سيف في السن ده مثلا، فاحتمال ده عشان
هو انتوا قلتوا سيف خلاص.
يعني واحد جربه يعني اقصد هو جرب الدراج ده في السن ده عشان كده اتحط، لكن اقصد ما فيش حاجه ثانيه حد يجرب حاجه ثانيه في السن ده.
بس طول عمره هو الدي 4 inhibitors have been يعني have been tested in this age and they are safe drugs. Number 2 I think ان احنا لما بنحط guidelines لازم الكلام very precise. كان يقول لي in obese patients I prefer to this drug GLP-1 receptor agonist and
هي احتمال يا دكتور حسين عشان هي تايب 2 دي اساسا هم تايب 2 ادوليسنس بيبقوا اوبيز.
بس الطعام لازم كان يسبايس يعني ده specification in the guidelines. يعني يقول لي if they are obese patients I would prefer to use this drug. If they are not obese patients you can use other drugs. I'm not sure طبعا.
ما هو الادوليسنت تايب 2 ده هيبقى ايه؟ لازم هيبقى اوبيز. ما لازم هيبقى اوبيز، ما هيبقى ايه؟ ما لو مش اوبيز يبقى مش تايب 2.
يبقى موجي حاجه ثانيه، دخلنا في حاجه ثانيه.
يبقى حاجه ثانيه
ودخلنا بقى في الفاريانس.
يمكن كانت عايزه بس انها فعلا تتوضح بكلام صريح يعني.
انا بس كنت مستغرب من الجايد لاينز ديت يعني هي معموله.
وحضرتك ممكن يا دكتور عمر تبعت للدبيس، ممكن تبعت لهم يعني تقول لهم الريكومنديشن بتاعتك دي او النوتس بتاعتك دي. بالعكس دي حاجه مفيده جدا ان حضرتك تبعت لهم وهيردوا اكيد.
هبعتها لك وهبعتها للدكتور حسين بالايميلز بتاعتهم، اقرا بيكتبوا ايه. وانت طبعا ايه يعني ساعات بنقول احنا بنقول حاجه واحنا مش مقتنعين بيها، بس الجايد لاينز بتقول كده يعني فاهم قصدي؟ يعني قدمنا حاجه هي مكتوبه كده بقدمها كده، بس هل احنا هنعمل كده؟ هو ده السؤال.
انا حضرتك طول عمري انا متفق مع طول عمري
بديل
يعني نرجع لشرحها ونشوف هل هو حاجه معممه ولا انسيرت
ولا هي في الاوبيز.
الجايد لاينز يعني مش كونسنسس ستيتمنت كمان يعني اكيد معموله على حاجه يعني. بس هي
نفس الكونسيبت دكتور عمرو وكان برضه يقول لي في الليت اونست يعني اشمعنى الادوليسنت. يعني هو برضه كان يقول لي ان الاوبيز بيشنتس اللي هم الاباف 40 to use GLP-1 receptor agonist. يعني كان هو لو هو بيعممها واعتبر كده كان برضه يحطها في الاولد ايه في مش في الاولد ايج في الليت اونست دايابيتس above 40 if he's obese this is the drug of choice.
يعني انا مقتنع بكلامك جدا فاهم قصدي؟ مقتنع ما احط اقراص احسن من الحقنه يعني حقنه ايدي اللي هياخدها.
هناخد في سيماجلوتايد بقى ما ينسى.
اي حاجه بقى، احنا مالنا مره في الاسبوع حتى. بس في الشير نوت ابروفد.
السيما لسه ما خدش.
الحقيقه ما رجعتهاش، بس هي اولا الدواء يعني لسه نازل بقاله ما فيش يعني شهر ولا حاجه. احنا خرجنا على الموضوع.
مصر دلوقتي يا دكتور عمر موجود في مصر؟ موجود في مصر السيماجلوتايد موجود في مصر دلوقتي؟
موجود.
اسمه ايه؟ بيتنطق ازاي بقى؟
الدوز الكبيره مش موجوده لسه.
بيتنطق ازاي يا دكتور ايناس؟ النطق بتاعه ازاي؟
ربع ونص وواحد.
ده الدوز الانتي دايابيتيك دوز. طيب احنا عشان ما نعطلش الدكاتره.
ريبالسس باين ولا حاجه اسمه كده؟
كمل. لا
بنتكلم على الدايابيتس بس، تاني نقطه.
طيب نرجع تاني لموضوع محاضره الدكتور حسين. دكتور عمرو، ما عندكش كومنت على محاضره الدكتور حسين او سؤال؟
لا يعني هو الدكتور حسين يعني غطى كل الجوانب سواء استخدامه في الرينال والانديكيشنز وكل حاجه، فيعني الحقيقه هو غطى الموضوع كله يعني من اول لاخر.
طيب تمام. احنا طبعا بنشكر حضراتكم جدا، بدايه بالدكتور عمر السعداني، استاذ دكتور عمرو المليجي، استاذ دكتور حسين الفيشاوي. بشكر نقابه الاطباء ووكيله نقابه الاطباء استاذه الدكتوره رانيا العيسوي على مشاركتها معنا جدا، وبشكر شركه نوفارتس، وانتظروا حضراتكم الماستر كلاس القادم ان شاء الله. وطبعا بشكر بيور سبوت على الاي تي النهارده. شكرا لحضراتكم وتصبحوا على خير. مع السلامه.
شكرا صباح الخير. شكرا دكتور عمر. شكرا دكتور ايناس. شكرا. السلام عليكم.
مع السلامه.